Okay, previous one. So this is the LED QFR. We can see the value is 0.6. Certainly also could be treated.
Yes.
So very diffuse, severe calcified lesion. And the virtual standing technique showed if implant maybe two stand from the middle LED to the proximal LED, the residual QFR should be 0.99. Okay, previous one. Let's see the circ again. Okay. We can see that really the circ is a diffuse disease, but the most functional lesion should be the proximal one.
Yes.
And the QFR of the circ is 0.73. And theoretically, if we implant a stent in the proximal portion of the circ, the residual QFR should be 0.95. Okay. So I think for the chip lesion PCI, the imaging is of great importance. Would give us more valuable information, and we did CT angiography for this patient. We can see this is a LED. We can see in the proximal portion a very huge calcium burden. Okay, next. Okay, this is the circ.
Yes.
The circ from the CT we can see only mild, only a mild calcium plaque. Both all very relative soft plaque. Okay, in the circ. Okay, next. Okay, so this is the CT angiography, the common CT angiography. So especially for the LED, we couldn't know the distribution of the calcium, the relationship between the chamber, the mitral chamber, and the calcium plaque. So we did the 3D reconstruction. We call that intelligent visualization system based on the CT angiography and the 3D reconstruction. We can see very clearly where is the vessel and the plaque and the plaque distribution and different part of the aorta and the coronary artery and the plaque in different color. So we could delete the aorta first. Okay, delete the aorta first. Delete the calcium of the aorta. Delete RCA. Okay, delete the RCA. We could clearly see the left coronary artery. Okay, the yellow one. Okay, delete the stent. Okay. So this is the left coronary artery. We can see the light blue one is the LED, and the green one is the circ.
Yes.
From this view, we could see a little bit brown plaque. Brown means relatively soft plaque, but we couldn't see the calcium plaque. The calcium plaque in the system we use the white one, white color. Okay.
Yes.
But when we rotate the LED. Okay, please rotate the LED. We could see where is the calcium plaque. Okay, rotate a little bit. Okay, we can see clearly. So where is the plaque burden? Okay, rotate a little bit more to the IVUS renal. Okay, we can see where is the calcium plaque. Okay, so just the calcium plaque in one side of the LED.
Yes,
okay,
the lateral side of the LED.
Okay. There is a big diagonal branch, and rotate a little more. We could see from different view. Okay, rotate a little bit more. Okay, rotate more. Okay. So the LED proximal, we can see diffuse lesion, severe calcification, and here there is a small tips and tricks. So when we advance the guiding catheter, we feel resistance in here.
Okay.
So here should be there is a plaque.
Yes.
Certainly, what we could do is sometimes we could rotate to change the direction, because forceful advancement of the tip may cause a Riser effect.
Yes.
Riser effect may cause a disruption of the aorta plaque, may cause injury. So very dangerous. So how to do? I already rotated the guiding, but still couldn't advance. And then I do a IVUS for the circ. Please show the IVUS of the circ. Okay. Please let Dr. Chao to introduce the IVUS result of the circ.
Okay, this is a pullback from the circumflex. We can see from the distal part of circumflex, there is a long diffused stenosis. And after we come to the proximate part, we can see the plaque burden reduced dramatically. And the lesion length is now so severe, we can see that there is a eccentric and fibrotic with a mild calcification in the median part.
Okay, so Dr. Chao already showed the result of the IVUS. We can see we didn't put the wire into the real distal because we can see very diffuse lesion. So we only need to implant a stent just at maybe it should be the proximal near the ostium of the circ and relatively short stent, because the virtual standing technique already show us the most functional segment should be the proximal one. So after I use 2.015 balloon to the inflation and implant 2.2516 stent and in the proximal circ, and after stent implantation and use IVUS to check and use 2.515 post-dilation balloon to do post-dilation. And in the distal part, use the 2.5 balloon to do the post-dilation. Okay, so let's see the final result of the stenting. Okay.
For this patient, I think first this is a typical CHIP patient because it's a 3-vessel disease with a very severe calcification at the proximal part of RAD. And also, I'd like to have a comment about the stress needs of this patient. Of course, CABG could be one choice for this one because there is a lot of plaque burden and the disease, long diffuse lesion. But if we pay more attention, we can see that all these severe stenosis are mainly distributed at the proximal part of the vessel. So I think that under the guidance of intravascular imaging, the complete revascularization for this patient could also be a great choice. It is what we are doing because the CABG was declined by the patient. We know that calcification is associated with a high prevalence. I mean, according to the previous manuscript, we understand that over 50% of the procedure is associated with
so the audience for IVUS.
Okay, so we are pulling back from the RAD.
Okay, let's check the RAD. Here is soft plaque.
Yes, so we can see the mid-proximal RAD seems like a 3-0 vessel. Okay, so here we comes the eccentric calcification. Seems like a very superficial with a little bit circumferential calcification. Here is a lot of attenuated plaque with the superficial calcification. I think that this result matches the CT angiography a lot because we can see a lot of eccentric superficial calcification.
Okay, Dr. Chao already showed the audience the result of the IVUS, and just like the CT reconstruction showed us, the distribution of the calcium should be totally on one side.
Yes, lateral side.
Side. And eccentric plaque.
Yes.
Plaque.
Yes.
Okay. So at present, we will to use the rota to debugging the calcium lesion to reduce the plaque burden.
Okay. Yes. Excuse me, Professor Lee, what's the name of the catheter again?
Should be True Cross.
True Cross, okay.
Okay.
So this seems to be a flexible one.
Okay.
We can see the rota wire has been sent to the distal part of RAD. I think What size of burr, Professor Lee, are you going to use for this one?
So for that case, I prefer to use 1.5 burr because as we know, the diameter is the IVUS caster could be easily advanced.
Yes.
But very huge calcification just in one side. So I think the shockwave technique should be used for this case. This is called rotalysotripty technique.
Okay, let's check the first round of rotation. Okay.
Okay.
I think everything is good.
This
Okay,
case.
I think that during the time Professor Lee just do the manipulation of the rotor burr, we can recheck the intravascular imaging about the wear bias. Let's check the pullback from LED. We can see, although the wear is not closely attached to the... Okay, I think that for the most severe part, the wear bias is relatively good. We can see it's very close to the superficial calcified plaque. So I think 1.5 burr can do some debulking to reduce the superficial calcification.
Okay.
I have confidence in the wear bias for under this case because we can see it's relatively close.
Okay. The pressure is good. The heart rate is good. Everything is good.
Yes, just like the demonstration of Professor Lee, that after each time that we do the rotablation, we need to check the flow, check the heart rate, and also the blood pressure of the patient to avoid some slow flow phenomenon. And also, we know that with this long diffuse the calcification, sometimes we can see that the flow could be affected by some small plaque crack.
Okay. Test.
Okay, I think the flow is good. We don't have to worry about it a lot. Actually, in addition, that we know that during the rotablation, we need to manipulate the rotor burr very carefully, so that the movement should not be very fast and very aggressive. So that should, and we also should watch the movement of the burr to avoid it's stuck during the plot or within the getting test.
Okay, I think we should polish the lesion.
Okay, so we can see that the speed is 148. Yes, 148, 150. And now it's going through the calcified layer very smoothly.
Okay, I think.
So we usually use several intracoronary injection medications for the slow flow phenomenon. For example, there is a natural prostate and nitroglycerin, of course, yes. So we can see that we withdraw the rotablation burr at a low speed. This is the most quick and effective way to withdraw the rotablation burr.
Okay.
Okay.
20.
So we can see that Professor Lee is changing the rotablation wire to the workhorse wire.
Okay, done. Okay, one thing we should pay attention is in the middle portion if there is myocardium bridge. But for that case, we didn't see the myocardium bridge. This is very important. Okay, go on.
Yes. Okay, like Dr. Lee said that to avoid the myocardium bridge is of key importance because we do not want to see the distal, target lesion failure.
And
you can see the IVL balloon has been
inflated with full atmosphere.
Okay, full atmosphere.
We can see. Okay.
I think this is a dog bone sign, although it's not typical.
Okay.
多大点？认了啊，是多大点？听到了吗？
Okay, already work.
Yes. I
Each
think this.
time
Mhm.
10 bursts. We can see the balloon a little bit.
Slowly, yes, opens
Okay.
a little bit.
Okay.
Yes. Mhm.
Down. Six. Okay.
Now we are
Down.
yes going to 6. We can see that balloon is opens much
Much
faster
better.
as compared to the previous one. A little bit dog bone sign at the beginning.
Down. I think we need one more.
Mhm.
Okay. Test a little bit.
So we can see we are not using the IVL as balloon to dilate the lesion, but we are just
Yeah.
using the balloon to attach to the vessel wall because the ultrasound can pass through the liquid very good, but not the gas.
Okay. 6. Down.
So in the traditional balloon-based plaque modification, a lot of dissections and hematomas could be seen. So this is the advantage of rotablation and IVL. We can see there is no, yes, a little bit intima dissection, but not severe. Yes, the crack of the superficial. We can see this is a very typical crack of the superficial calcification. A good variation from the rotablation. Let's
Okay.
check the proximal part. I think the proximal sheath is the most variable situation. Okay, this is a very good crack from the lateral side of the superficial calcified sheath. I think this is a good promise for the static expansion. Also here, yes, the proximal part, there is a crack of the superficial calcified sheath. But the osteum RID, I don't see a clear landing zone, so maybe we need to protrude into the left main. Let's check again.
Okay. Stop.
Okay, let's check again. For the distal part, the most severe stenosis part, we can see some intima dissection due to the IVL balloon usage. And also here, we can see this is a very typical, very good sign of calcified crack. Here we can see without hematoma, without big dissections. And also here, the good, ultrasound reverberation. This is the promise of a good rotational atherectomy because we make the superficial of the plaque very smooth and we come closer apart. There is small dissection at the lateral side because it's a complete calcified sheath. Here we can see the bilateral side of the calcified sheath. There is a wear, artifact. It's hard to tell whether after this one there is a crack or not. But however, all this kind of bilateral side crack is a good promise for the balloon and also the stent expansion.
I think no problem.
Okay, good, very good. Yes, don't have to worry about it.
So okay, we'll go a little bit further. Okay. Okay, I think everything is good. Okay, here inflation. Slowly, a little bit. For the lacrosse balloon, inflate should be a little bit slowly.
Yes.
Yeah, a little bit slowly to 10.
Okay.
Slowly.
I think it opens very well.
Okay, 12. Okay, down. The balloon inflate is good. Okay, here inflation. Sometimes even the balloon needs strong resistance. So the, okay, 10, 14. Okay. Down. Okay. Here, once more. 16. Okay, down. So all the balloon already well deployed. Okay. Okay. Yeah.
Actually, I think that from the NRC balloon open, we can see that it's relatively good. We need to confirm with IVUS again.